This presentation is mostly based on NICE guidelines on acute heart failure, which was last updated in November 2021. I've also consulted heart failure management guidelines from European Society of Cardiology, as well as other great resources such as uptodate.com and BMJ Best Evidence website. Without further ado, let's start with the definition. Simple definition of heart failure is it is a condition in which the heart does not pump enough blood to meet all the needs of the body. Acute heart failure can present as new onset heart failure in people without known cardiac dysfunction or as acute decompensation of chronic heart failure. It can result from an abnormality of cardiac structure or its function. Most important causes of acute heart failure are: number 1, acute coronary syndrome; number 2, hypertensive emergency; and number 3, tachyarrhythmias or severe bradycardia or conduction disturbance. Other causes include acute mechanical cause like ruptured interventricular septum or acute mitral regurgitation as a complication of acute coronary syndrome, acute pulmonary embolism, infections including myocarditis and cardiac tamponade. Clinical features: the onset and severity of symptoms of acute heart failure vary and depend on the nature of the underlying cardiac cause and the rate at which the syndrome develops. Patients typically present with sudden onset of shortness of breath and overwhelming sensation of suffocation and air hunger. The other symptoms are cough, expectoration of pink frothy sputum, sensation of drowning, and extreme anxiety. The physical examination findings are tachypnea. Patients will be sitting upright using accessory muscles of respiration and unable to speak in full sentences. Tachycardia. The pulse rate is most often elevated, secondary to an increased adrenergic drive. It may be low in presence of acute coronary syndrome and cardiac arrhythmias. The oxygen saturation is usually less than 90% on room air before treatment. Auscultation of the lungs reveal coarse crepitations with wheeze that are detected first at the lung bases but then extend upward to the apices as the pulmonary edema worsens. Cardiac auscultation may be difficult in the acute situation, but third and fourth heart sounds may be present.